Good afternoon, folks. If you're joining us via computer or via phone, and you're able to see your screen and you're able to see my screen, I'm just going to ask you for a few favors. If you could just text in the chat box your name and your agency, and also confirm that you can see my screen. On the screen, it should say you should see the Project Echo logo and the words Hartford Health and Human Services, Connecticut. So if you could just text those two pieces of information in the chat box, that would be greatly appreciated. Thank you, Blaze. Thank you, Yolanda. Thank you, Bernie. For those who are just joining us, we're just going through a quick tech assessment and asking for folks if they can see my screen and if you're able to hear me. Blaze just let me know that he cannot see my screen. Blaze, I just fixed it. Can you see my screen now? For those who are just joining us, we are just going through a quick tech assessment before we start. And I'm asking folks to introduce themselves by stating their name and agency they're calling from, and also making just a confirmation that you can see the screen. So I've just fixed the screen, and Latoya Tyson just confirmed for me that the screen, she can see the screen. Thank you, Cherry, from Latino Community Health Services. All right, good afternoon to those who are just joining us. My name is Siso Tengatenga, and I am the project manager for the City of Hartford's HIV HCV core infection project that we call here Project Access, which stands for Achieving Comprehensive Coverage Early, Systematically, and Sustainably. We've been implementing the project beginning in 2016, and we're coming up the end of our implementation just this June. But the final project end date is in September, and we have some exciting news about the future that we'll share in this presentation. I'm just going to confirm. I see a couple of folks who just joined us. For those who are joining, we're making sure that you can see and hear me by sending a text message via the chat box to confirm that you can see the screen and also hear my voice, and a quick introduction that includes your name and the agency you're calling from. And Dr. Wu, if you could just confirm by saying something through the mic. I've just unmuted your phone so we can start the presentation. That'll be great.
Gotta put you on speaker.
Okay, perfect. That's great. So I will mute you for now, and then once we get to your presentation, I will unmute you, and you can direct me through the presentation. All right, folks, thank you for joining us. There is quite a big crowd today. I'm excited that we have Dr. Wu today, who's going to be speaking to us on hepatitis C and cirrhosis, and also making a couple of recommendations about how you can incorporate some of this work into what you're already doing in your projects. For our overview today, I'll go briefly through an introduction and mostly focus on our project and where it's at. And then I will transition us into Dr. Wu's presentation. And after that presentation, you should be able to engage him either via the chat box or by, muting your phone and asking him a question directly. And then we'll conclude. So as far as our project access, so we began implementing our project, as I said, in 2016. And at that point, the goal was to identify, link, and treat all HCV patients we could identify within the Ryan-White continuum in the Hartford Transition Grant area. When we did our preliminary findings, we had identified about 631 individuals who were co-infected. That did not mean that all of them were chronically infected and eligible for treatment. Just a subset of those were found to be chronically infected and were initiated into treatment beginning in 2016. Some of them were already on treatment, but for our project, we were tracking about 545 individuals. We were lucky in that many of our providers, some who are here joining us on this call, had been treating aggressively that population. For those of you who remember the old Hep C medication, you would know that interfering, there were a lot of treatment failures and a lot of resistance from folks to come back to treatment. But we were lucky in that in our transition grant area, our providers were aggressive and sort of like, ahead of the curve in terms of when the new medication came in, really ramping up and engaging that patients and clients into treatment. But we also did identify a couple of barriers, which I think these are just unique. Some of them are unique to Connecticut, but some of them are just unique to hepatitis C as it's been implemented elsewhere throughout the country and across the world. Some of them were structural. The need for surveillance was pretty high for us. We needed to create a surveillance program that will be reliable enough to identify those who needed treatment, to link them, to monitor them through treatment, and then after treatment to be able to pass them on to the next provider or to primary care. There were also some community barriers that we encountered. Some of them just had to do with, information gaps that were out there in terms of how HCV is spread and how it's, what medications were around. So a lot of stigma was something that we try to address in our first year of putting out education. And then some of them were at the provider level. Luckily, many of our Ryan-White providers were culturally competent and did have the skills and capacity to really work around something we found among other providers to be challenging, which is to initiate treatment for those clients with histories of substance use. We were lucky that was not the case with our providers, but that's something that's just true to treatment initiation for Hep C in Connecticut and also across the country, as we have been seeing it in data. On the right there, those are some of the clinics that are participating in our intervention. So this is our treatment and patient navigation intervention. But beyond that, we have our community education network that expands beyond those providers you're seeing on the screen. In terms of updates, I'll only focus on the updates that are relevant to the group and to education, just because of time. But also, if you have any other questions, I greatly encourage you to reach out either via the chat box or to me directly, or Angelique, or anybody else in the Ryan-White program to learn more about our Hep C HIV co-infection projects. In terms of our dissemination plan, we are now in the phase of sharing some findings from our project. As I said, our measurement period ends in June, and we're a little bit ahead of the curve, and we've started producing and releasing, papers and also, patient education literature and training curriculums for different provider types. And we've been mostly focused on, developing these products in collaborative group workshops with other jurisdictions. So we created these national virtual forums where we meet periodically to work on an issue. And so far, we've been able to work on three of those issues. One was to work on, creating a surveillance program by integrating pharmacy systems to track HIV and Hep C surveillance. Which the paper is about to come out very soon. And concurrently with that, you'll also be seeing some piece of legislation that will be sent to your organization to support PrEP initiation among community pharmacists who go through a training that we're also developing. We also have standing partnerships with the New England AETC, and this training is actually being partly sponsored by them and our partners at the AETC at Yukon University. And we are delighted that some of our trainings, as we've curated them in our project, will be sent to that website so that made available to New England. Some of our partners and our plan for dissemination of our findings you can see on the screen. So without any further ado, I'll move on to introduce our speaker, Dr. Wu, who is the chief of the hepatology section at University of Connecticut, who'll be talking to us and on hepatitis C and sort of like, going through things like cirrhosis and also making some recommendations about, things that we need to be looking out for those of us who are on the prevention side and those who are on the treatment side as well. So Dr. Wu, over to you.
Thank you very much. It's a pleasure to have the opportunity to participate in this webinar. My experience is basically limited to the monoinfection of Hep C, so I'm going to focus on areas that I think are still challenging in the treatment of hepatitis C. So let me have the next slide, please. Just to give everyone some background, I think most of you know that hepatitis C is a significant health problem in the U.S. Estimated, even with the opioid crisis, we have about 4 million cases of Hep C in the U.S., but worldwide it's a tremendous problem with an estimated greater than 200 million cases. And even in the U.S., many thousands of new cases are diagnosed every year. I think it's fair to say that if hepatitis C were simply an acute infection, nobody would care. The problem is that 85% of acute exposures of hepatitis C do not clear the virus. In other words, they go on to chronic hepatitis and all of the potential sequelae. It may be of interest to the audience to note that in the U.S., where we have the option of treating failure with liver transplantation, it turns out that hepatitis C-induced liver failure is the most common indication for liver transplantation in the U.S. 51% of all cases of liver transplants are done because of hepatitis C-induced liver failure. The other point that I think in general that is worthwhile noting is that on the average, it takes about 30 years from the time of exposure to the time that patients will start to develop some signs of liver failure. So 3 decades, that is a long time. And the point I'm trying to make is that because the duration is so long, the progression is very slow. And for that reason, most patients have no symptoms, or if they have any symptoms at all, it is something nonspecific like fatigue. Next slide, please. So just a little bit of background about the virus itself. I think most of you know that this is hepatitis C is an RNA virus. It is membrane enclosed, and that membrane actually is derived from the host, the person who was infected. The virus buds out of the infected liver cell, taking with it membrane from the liver cells, and in that membrane is embedded proteins that are encoded by that virus. The virus is quite finicky. It really will infect only high primates, and although it has been documented to be able to infect non-hepatic tissues, clearly the replication of the virus prefers hepatocytes, and most of the replication of the virus occurs in hepatocytes. Having said that, it's important to note that the virus is not hepatotoxic. It does not by itself kill or damage liver cells. Instead, what happens is that as the virus replicates, it produces its own antigens, which, as I mentioned, become embedded in the cell membrane through which the nucleic acid buds to form new virus. That process of embedding viral proteins into the surface membrane results in a host immune response. And so the hepatitis and the liver cell damage that we see is basically an autoimmune response to the presence of viral proteins on our liver cells. The other biological point that is worth making is that because this is an RNA virus, RNA viruses in general, and with their polymerases tend to make mistakes. Not only mistakes, but they do not have what's called an editing function. They do not correct their mistakes. And that results in a high mutation rate. That is of importance because the fact that there is a high mutation rate means that all of the proteins in the virus tend to change. And it is that change that is thought to make the virus difficult to eliminate by the immune system, and that is partially responsible for the high degree of chronicity, and also for the fact that to date we have not made much progress in the development of a vaccine for hepatitis C. Next slide. Now, we talked about the worldwide distribution of 200 plus million people. As you can see on this map, geographic distribution of hepatitis C is by no means uniform. In fact, you can see that there are areas that have high prevalence, which would include many areas of Asia, East Asia, and Africa. And in particular, even within those regions, there are hotspots that have prevalences in excess of 10%. In North America and in Western Europe, the prevalence rates are much lower. However, because there is immigration from areas of high prevalence to areas of low prevalence, these numbers are in constant flux. Next slide, please. Now, as I mentioned to you, the virus is relatively simple, but it's important to understand the various structures. We talked about the membrane and the viral proteins that are embedded in the membrane. It is these proteins that interact with the host, in particular with receptors on liver cells, which mediate the internalization of the virus, which initiates the infection. It is worth noting that the nucleic acid within the virus is actually, the RNA is wrapped up in a protein shell, which is called a capsid, and that entire package is surrounded by a protective membrane that we discussed earlier. Next slide, please. Next slide, please. Next slide, please. Uh-oh. Next slide, please. Next slide. Next slide, please. Next slide, please. Something wrong with the audio. Next slide, please. Next slide, please. Next slide, please.
Hey, Lisa. Hey, we can't, the slide's not advancing. Okay, because I can pick it up on my end when I'm listening. So you can't advance it either? He is on speaker. He's been saying, okay, can you advance the slide then? Okay, so you're gonna call into the call. Okay, all right. Okay, all right. Okay, yep. He can't hear you.
Oh, you can't hear me?
But everybody else can, so they're hearing our conversation. Call in.
Hello?
Can you hear me?
Yeah, I can hear you now. Yep. Sorry about
Okay,
that.
great.
We just I lost audio over here, and I couldn't hear your instructions to move the slides. Now I'm
No
able
problem.
to hear you.
Okay, we can advance the slide.
Okay. Sorry, folks, about that little minor glitch. And we're going to resume now. Thanks.
Okay, just a few words about the organization of the genes of the virus. I just mentioned them because the proteins NS3, which is a protease, NS5A, an accessory protein, and the polymerase are the main targets for direct antiviral agents. These are the primary. These are the products of the virus that are currently the most successful in terms of inhibiting the virus. Next slide, please. All right, let's talk a little bit about transmission. It is very clear that the vast majority of cases in the U.S. are acquired through injection drug use. However, it is important to realize that individuals who receive transfusions of blood or blood products prior to 1992 are also at risk. The reason for this is that the hepatitis C virus was not identified until 1989, and it was not until 1992 that we had blood testing that was capable of screening our blood supply. And therefore, individuals who have had blood transfusions prior to 1992, especially those who have had multiple units, such as hemophiliacs, are at particular risk. It is also deserves mention that aside from injection drug use, intranasal cocaine use has been implicated as a mode of transmission. Many times we're asked about sexual transmission. I think it is accepted that sexual transmission does occur, but it is inefficient and unusual, and therefore the NIH and CDC do not recommend that stable partners make any changes in their sexual activities. Other than that, it's basically individuals who are exposed to blood frequently as physicians or healthcare workers have an occupational exposure, and renal failure patients who are on dialysis, of course, are frequently exposed to blood. Next slide, please. Just as a reminder about the sequence of serological events that occurs in this next slide, we see the pattern that is obtained in individuals who are lucky and recover from an acute infection. In this case, the hepatitis C RNA rises roughly at about the same time that the ALT increases, and somewhere in that period, one also can develop symptoms of acute hepatitis. Then, as the hepatitis C is eliminated, the RNA disappears, the ALT declines and becomes normal, and an antibody appears. This antibody is important in terms of diagnosis in that it is a marker of exposure. It is important to realize, however, that this antibody is not protective. Individuals who recover from hepatitis C, whether it be by treatment or spontaneously, are not immune to reinfection. Next slide, please. Now, this is the pattern that is more typical. So in 80 to 85% of acute exposures who go on to chronic infection, the hepatitis C RNA remains present, although levels can decline, and symptoms of acute infection resolve, and then most commonly, there is very little in the way of symptoms after that, as I mentioned previously. The pattern of liver enzymes will decline after the peak of acute infection, and the levels tend to vary. So they tend to bounce up and down. It is important to realize that, especially after many years of acute infection or many years of chronicity, the AST levels can be very close to normal, and in fact some do become normal at some point during the course. It is also important to realize that approximately 15% of individuals with chronic hepatitis C will have persistently normal ALT/AST values. Next slide, please. So, as I mentioned, the main problem with hepatitis C is chronicity. 80 to 85% of acute exposures will not resolve spontaneously. And over the course of about 3 decades, about 30% will develop cirrhosis. So cirrhosis is a problem for 2 reasons. One, of course, is that it is a reflection of scarring of the liver and reduction in liver cell mass, which eventually, as you can see with the left portion of the arrow, will lead to liver failure. About 30% of cirrhotics will eventually develop liver failure over the course of 10 years. The other arrow to the right is another very important complication of the development of cirrhosis, in that the risk of liver cancer is greatly increased once cirrhosis develops, and the incidence has been estimated to be up to 7% a year. Next slide, please. So that is hepatitis C alone. We're talking about 3 decades worth of progression. However, there are many factors that accelerate the process, including alcohol, and I'm talking about regular, steady alcohol abuse, the presence of hepatitis B as a co-infection, presence of HIV co-infection, and nowadays with this explosion in non-alcoholic fatty liver disease, fatty liver is also recognized as a factor that increases the rate of progression. Next slide. All right, so that brings us to who should be screened for hepatitis C. Clearly, because our prevalence rate is low in the U.S., it is not cost-effective to screen everyone. And therefore, we must be judicious in selecting those who should be screened. And that includes individuals who are current or have any history of injection drug abuse, individuals who have, as I mentioned, had a transfusion of blood or blood products prior to 1992, individuals who were ever incarcerated, patients who have renal failure and have had dialysis, individuals who know that they have been born to an HCV-positive mother. And then one of the most common reasons that we see in our clinics, elevated liver enzymes. Anybody who has unexplained elevated liver enzymes should be screened. And then anyone who has frequent exposure to blood as well. Finally, the last criterion was added fairly recently. Individuals who were born between the years 1945 and 1965, the so-called baby boomers, are to be screened because of the culture of drug experimentation in those years. Next slide, please. So how do we screen? I think that's pretty straightforward. The first and most common test is the hepatitis C antibody test. So this you have entered as an attendee in listen-only mode. This antibody is a measure of exposure. Remember that it is not protective. Other tests that should be done include liver enzymes, AST, ALT, as a marker of liver damage. And also, of course, one should screen for co-infections, including HBV and HIV markers. Now, the presence of hepatitis C antibody is useful as a screen. However, it is not conclusive. It is not a definitive test. The definitive test is measurement and determination of hepatitis C RNA by PCR, or the NAAT test, nucleic acid amplification test. This is the gold standard. If someone has a positive hepatitis C RNA, that person has hepatitis C infection, regardless of whether the antibody is positive or not. The other important piece of information to obtain is the genotype, and that, as we will see later, figures importantly in some cases of selection of the type of medication to be used. Next slide, please. The genotypes are not uniformly distributed worldwide, as you can see from this slide. The most common, the most prevalent genotype in the U.S. is genotype 1, subtypes A and B. About 75% of patients in the U.S. have genotype 1. About 20% have genotype 2, and the rest are scattered between the other genotypes. But as you can see throughout the world, there are other striking differences, including the fact that much of Africa is almost exclusively genotype 4. This is important, again, because some medications are better than others in treating certain genotypes. Next slide, please. So once screening is performed, if one determines and has documented the presence of hepatitis C RNA, that's not the only criterion. One also should have evidence of liver damage, and that usually includes AST and ALT elevations. Sometimes when AST, ALT are normal, a liver biopsy can be helpful in demonstrating the presence of either hepatitis as inflammation or the presence of cirrhosis or fibrosis. Next slide, please. All right, so that brings us to what is available for the treatment of hepatitis C. With the advent of direct-acting antiviral agents, this list covers the available agents. The ones that are in red have been recently withdrawn in the U.S., but the others are available, and the genotypes that can be used are as shown. It is worth noting that Epclusa and Mavorud and Vosevi are pan-genotypic, that is, they are useful for all genotypes. Next slide, please. Well, what about the efficacy? As you can see, we have come a long way from 1991, when interferon alone was the treatment of choice and the only treatment available, to the most recent years when we have direct-acting antiviral agents, which are now approximately 95% effective. When I say effective, I mean that they can expect 95% of treated patients can expect a sustained virological response, meaning that 3 months after completing therapy, their viral loads or hepatitis C RNA will be undetectable. Next slide, please. So, with such good efficacy, what challenges remain? And I've listed 7 of these that I'd like to review with you today. The first and foremost is that hepatitis C infection, in spite of our success, is not going away. And part of the reason is because of the opioid crisis. Second is that it has been recently shown that individuals who have co-infection of hepatitis B and C can develop a hepatitis B flare. And I'd like to say a few words about that. Also, individuals who have hepatitis C and are treated with certain strong immunosuppressants can reactivate, and that's something that deserves some discussion. We have some issues with who and how much renal insufficiency can be tolerated and which agents should be used in those situations. Also, patients who have cirrhosis, in particular patients with decompensated cirrhosis, who should be treated and with what. Finally, we're left with drug interactions, which are quite numerous with most of the direct-acting agents, and of course, treatment access, which involves cost. Next slide, please. So let's talk about hepatitis C infection and the opioid crisis. We all know that there is a disaster out there with individuals abusing intravenous drugs. And the story begins with the introduction of OxyContin or oxycodone in the 1990s, which were initially, described as less addictive and encouraged for individuals who had painful conditions. Then the crisis, because of the numbers of addicts, the U.S. government declared that the abuse of these drugs should be curtailed as much as possible, and that was accomplished by stronger oversight and restriction of the prescriptions for opioids. This restriction made the opioids less available, and as a result, individuals have resorted to other substitutes, including heroin. And this has then led to a great increase in the intravenous injection of heroin. So, next slide, please. How has this affected hepatitis C? That is shown in the next graph, where you can see that from 2004 through roughly 2007, the rates of hepatitis C and injections were relatively stable, and then there was an explosion, a exponential increase up through the present. And you can see very clearly that the rates of hepatitis C paralleled in terms of slopes the admissions or the documented increased use of opioids by injection. So it's very clear that as intravenous drug abuse has increased, so too has the prevalence of hepatitis C. Next slide, please. Now, it's just a few words about hepatitis C flares in individuals who have been treated, who have hepatitis B and C co-infections. This is actually, I think, quite interesting biologically, in that if in the normal situation where you have a co-infection of hepatitis B and hepatitis C, the two viruses compete with each other for cell nutrients. And the hepatitis C tends to be dominant, and in that situation, there is somewhat of a natural suppression of the replication of the B virus. So, in individuals who have hepatitis B, hepatitis C co-infection, if those individuals are treated only with anti-hepatitis C drugs, that releases the suppression of the hepatitis B virus and is manifest by an increase in replication of the hepatitis B. And in fact, flares have been clearly documented. So it is recommended that for individuals who have hepatitis C, first of all, they should be screened for hepatitis B, and under certain circumstances, they should be prophylaxed. Next slide, please. So this is an algorithm that describes what should be done for individuals who have co-infection B and C. The hepatitis B core antibody is used as a reliable measure of prior exposure. Generally, we check core antibody and surface antigen at the same time. But the point is that individuals who have a marker of exposure with anti-core should undergo further evaluation. Individuals who have no hepatitis core antibody, have not been previously exposed, do not need further consideration. So those individuals who have been previously exposed, as I said, determined by the presence of core antibody, should be checked for surface antigen. And in general, individuals who have surface antigen should be treated. They should first be tested in terms of hepatitis B DNA for a baseline, but then they should be treated. Now, in some cases, individuals who have surface antigen and do not have antibody, those individuals, it is recommended in certain guidelines to continue testing until of the liver enzymes, and if hepatitis B DNA becomes detectable, they should be treated. I frankly think that most patients who are surface antigen positive and are treated with anti-hepatitis C agents will become DNA positive. It makes more sense to simply treat rather than to follow. Individuals who are surface antigen negative should be monitored for the development of surface antigen. And if surface antigen becomes positive, they should then also be treated after obtaining baseline hepatitis B DNA. Next slide, please. All right, so this is just a summary of what I mentioned. Isolated hepatitis C antibody, that is just a measure of exposure without surface antigen, should be monitored, and if surface antigen becomes positive, the DNA should be checked and they should be treated. Individuals who are surface antigen positive, if they have DNA, should be treated, and if they do not have DNA, you have the option of monitoring or treating. Next slide, please. All right, now let's talk about hepatitis C reactivation. So by reactivation, we define that as an increase in hepatitis C RNA of greater than 1 log over baseline. And this tends to occur when patients are exposed to strong immunosuppression, as in the case of chemotherapy or immunosuppressives, say, for autoimmune disorders. And the fear here and the possibility is the development of a hepatitis flare, meaning greater than a 3-fold increase in ALT, and ultimately the possibility of acute hepatic failure. Next slide, please. So this area has been studied, and it has been found that about a quarter of patients who had chronic hepatitis C who received cancer chemotherapy developed a reactivation, and about half of these reactivations developed a flare, which is quite significant compared to only about 15 to 16% who did not reactivate. About a quarter of the patients who developed these reactivations had to reduce their doses of chemotherapy. However, it is comforting to note that none of the reactivations developed acute hepatic failure. Next slide, please. So who should we be concerned about in terms of reactivation and flares? Individuals who are treated with very strong immunosuppressants, such as rituximab, and very high-dose steroids, such as the equivalent of 600 milligrams or greater of prednisone, and individuals who have high viral loads to begin with, RNAs greater than 10 to the 6th. So the conclusions are in this topic that reactivation actually is quite common, but tends to be mild. So the potential risk for developing hepatitis C reactivation in and of itself is not a contraindication for chemotherapy. However, patients should be monitored for the development of flares and to prevent the rare development of liver failure. In such cases where there is a flare, one may consider treating with direct-acting antiviral agents to result in HCV suppression, either before or in combination with chemotherapy. Next slide. All right, so another problem that we commonly see is how to treat patients with hepatitis C who also have renal insufficiency. And as you can see from this chart, there are agents who have no limitations with regard to GFR, the top three, whereas the bottom three can be treated in individuals who have GFRs greater than 30 and should not be used in individuals who have less than that. Next slide, please. And what about cirrhosis? This is a rather common question. And I summarized for you here the agents that have recommendations for use in cirrhosis. First of all, with regard to the classification of cirrhosis, for Child-Pugh class A, that is compensated cirrhotics, all of the agents are okay. However, for individuals who have evidence of decompensation, that is child class B and C, you can see that the top four are not recommended for use in that situation. But in the case of Harvoni, it is permissible to use that agent, but it is advised to use caution, meaning that the liver tests should be monitored closely. In the case of Epclusa, there is no limitation. However, ribavirin should be added in the cases of advanced liver disease, class B and C. Next slide, please. All right, a few words about cirrhotics. We talked about how to treat cirrhotics depending on their Child-Pugh class. It is important to remember the fact that cirrhotics have a tremendously increased risk of developing liver cancer. And I wanted to emphasize the fact that this risk remains even after the hepatitis C is cleared. And therefore, individuals who have cirrhosis and are on treatment must not be lost to follow-up. They must be screened every 6 months with an ultrasound, and in some cases an alpha-fetoprotein may be helpful, but all these patients should be screened and not lost to follow-up. In our practice, we have had a number of patients who have been treated on the outside successfully, clear the virus, only to return several years later with the development of inoperable hepatocellular carcinoma. Next slide, please. All right, let's talk a little bit about drug-drug interactions, as this is actually quite common. There are, because the direct-acting antiviral agents all consist of combinations, the risk of interactions with other drugs is accordingly increased. And some of the more common ones include PPIs, which tend to decrease the effectiveness of Harvoni, Epclusa, and Mavorite. That is because the solubility of one of the agents is decreased as pH increases. So the PPIs tend to decrease the absorption of some of these agents. There are many other interactions. It's not possible to review all of those, but I think I list on this page the University of Liverpool website, where very useful and easy to interpret tables are available to advise about how to adjust and which agents to use in the presence of possible drug interactions. Next slide, please. All right, let's finally a few words about cost and access. So even in the U.S., where we have resources, great resources, the distribution and affordability of agents against hepatitis C is quite variable. And it turns out that as the efficacy of the antiviral agents has increased, so too have the prices. Next slide, please. So on this chart, you can see that considering the wholesale cost per treatment on the y-axis, you can see that the agents that beginning with relatively ineffective agents were also very cheap. But as with the introduction of direct-acting antiviral agents and highly effective agents, we see that there has been a dramatic increase in the cost of these medications, where costs peaked in around 2015, where the cost of Harvoni was about $1,000 per pill, or $90,000 for a course. Now, since then, you can see that there has been a significant drop in the wholesale prices, and that has been due to primarily competition and also government and public outcry about the exorbitant prices. Nevertheless, the costs are still considerable. Next slide, please. So Harvoni and Epclusa now are generic, which has contributed to availability. Another factor that should be considered is that in certain circumstances, Harvoni and Mavorite can be used, the duration of treatment can be as little as 8 weeks, which can cut the cost to $24,000 per treatment. I think as time goes on, and in particular, if more agents are added to the armamentarium, the impact on cost will be significantly improved. Next slide, please. So let me summarize by reminding you that hepatitis C is a common infection, and because of the slow progression, it is characterized by few symptoms. However, most of the individuals who are acutely infected will develop chronic hepatitis, and those individuals are at risk for developing cirrhosis. About 30% of all cases will develop cirrhosis. Important to remember that those individuals who do develop cirrhosis will have a greatly increased risk of liver cancer even after clearing the virus, so that liver cancer screening is mandatory in individuals who have cirrhosis. And that goes for cirrhosis not due to hepatitis C. Any individual who has cirrhosis should undergo liver cancer screening. Remember that the opioid crisis is ongoing, and there is a continuing and dramatic increase in hepatitis C prevalence, and that we must screen these individuals based on risk factors, which include baby boomers with certain birth dates, and use antibody to screen, but confirm by using hepatitis C RNA PCR or the NAT. Remember that individuals who are co-infected with hepatitis C and hepatitis B, if treated for hepatitis C alone, run the risk of developing hepatitis B flares. So individuals with hepatitis C must be screened for hepatitis B and in certain circumstances treated prophylactically. Next slide, please. Remember that hepatitis C reactivation can occur in the presence of strong immunosuppression. Most of the times this occurs in the cases of cancer chemotherapy and is not a contraindication to chemotherapy, but it behooves us to monitor individuals for the possibility of a flare, and if a flare occurs, hepatitis C treatment may be indicated. Other problems include renal insufficiency. Remember that Mavorite and Zepatier are not renally excreted and therefore are useful for individuals who have renal insufficiency. For cirrhosis, all of the direct-acting antiviral agents are approved for child's A, but for child's B and C, only Harvoni and Epclusa. And for Harvoni, that should be followed carefully by monitoring liver enzymes. The drug-drug interactions are common. The tables that I showed you are useful for avoiding those interactions, and costs remain a major issue in access of our population to the DAAs. Next slide, please. So that's it. Thank you for your attention.
Thank you so much, Dr. Wu. And again, apologies for the minor technology glitch that we had with the audio. But this was such an insightful presentation, particularly honing in on cirrhosis, but also Hep C and Hep B co-infection. I have started a question thread in the chat box. For those who are waiting to be inspired, you can look into the chat box for some inspiration to questions, or if you're ready with your question, just raise your hand and I will unmute your phone and you can ask Dr. Wu any question. While we're waiting for that, Dr. Wu, I was wondering if you could speak a little bit more to what will be your recommendations for providing case management to those patients who are HIV, Hep C co-infected, who are also diabetics when it comes to thinking about, liver health?
Okay, let's see. Well, with regard to comorbidities, including fatty liver, diabetes, HIV, HBV, as I mentioned, especially for fatty liver and the other viruses, the progression of the hepatitis is more rapid. So in that situation, we're not talking about 3 decades any longer. We're talking about considerably less. And so these individuals have, accordingly, less time to be treated before the onset of irreversible disease. So that's I think number one. Number two, the issues of drug-drug interactions between the hepatitis C antiviral agents and other antiviral agents need to be considered. So certainly these other comorbidities complicate matters, but they are generally solvable.
Thank you for that response. And I do have a hand that was raised here. Danielle, you should be unmuted now, and you can ask the question.
Sorry, could you repeat that?
Danielle, who's on, I'm looking at my sort of screen here for people who
Yes.
are queuing up for questions. Danielle, are you able to speak to the phone? I've just unmuted your phone. Hey, Danielle.
Hi. Yes, I thought I had typed my question in. As far as exposure, and this can go for both of you, Cecil, and the doctor. With the project that the city did, was there a component that did partner notification? I know that, well, some of the things that I read was that if the partner is HIV positive to a person who is Hep C positive, the HIV positive partner is more at risk of contracting hepatitis C. And also, in terms of intravenous people who use IV drugs who are hepatitis C positive with their partners, because in the early years of HIV, it's how we found other folks living with HIV was also partner notification of those folks who shared or got high with their partner, with other folk on a regular basis. So that's my question.
All right. Well,
Okay.
with regard to transmission, it is most common that individuals who are co-infected with HIV and HCV tend to have much higher viral loads of HCV. And in general, the transmissibility, the rate of transmission of hepatitis C does parallel the viral load. So in that respect, regardless of the status of the recipient, the individuals who have co-infection would tend to have higher viral loads of hepatitis C and have a higher rate of transmission. For the recipient, if the recipient is co-infected, if the recipient has HIV, I think I'm not aware that if they're treated and their CD4 counts are okay, that they're any more susceptible to HCV.
Thank you.
Okay.
And Cecil, was partner notification a part of the?
Sorry, Daniel. Yes, I'm not sure what happened to your mic here. But to answer your question, so in terms of the way we approached the project was, primarily looking at a subset of the HIV population that are co-infected with Hep C. So all the standard care practice for partner notification might go with HIV clients within the YMI program, including your program. Those were held steady, so nothing changed. I think we encouraged the patient navigators who were trained, but also the community outreach teams that we reach out to in terms of the community health workers that were trained to utilize partner notification. So we did not change anything else. But to your question, as you're asking, I'm thinking about something that we didn't do in the project, which I think Dr. Wu highlighted in this presentation, was Hep B. We never really focused on Hep B, and I'm wondering if anybody else on the phone who are doing prevention or even from Dr. Wu, if you would make recommendations that when we suggest ways of reaching out to folks who are co-infected with Hep B, should we be looking into rapid tests, Hep B rapid tests in the field? Because it does sound like with Hep C, Hep B co-infection, the risk for both flare-ups but also liver deterioration increases with that co-infection. So I know there are a couple of outreach folks on the phone. I see folks from ACT. I see folks from LCS. I also see some nurses from CHC. I'm wondering if your outreach teams are thinking about Hep B in light of Dr. Wu's presentation, emphasizing that it's not just about the Hep C and the HIV, but it's about both the HIV, the Hep C, and the Hep B. If you feel inspired, you can share your thoughts in the chat box, but also you can share one useful information that might perhaps be important to us, which is, would you want a training for your outreach teams to be trained to do Hep B rapid tests in the field? If so, just either unmute your phone, or you can just put it in the chat box. We'll move on to other questions. Is anybody having a burning question that has not been addressed in Dr. Wu's presentation before we wrap up? You can raise your hand, or you can also text in the chat box. Seeing that there is none, I will lift one of the questions that I put in the chat box for Dr. Wu, which is, how would you, and this is based off of your vast experience in transitioning patients as they're finishing up the Hep C treatment, and so putting them under Hep C HCV surveillance. What are some of the best practices that your clinic has been implementing? And here I'm thinking particularly, your nurses, and if you have any other ancillary health workers within your clinics, what are some of the ways that they're able to engage those who've been treated to come back for those additional tests after they've been treated with Hep C?
Sorry, could you repeat the question?
So the question is in terms of best practices after Hep C treatment, and
yes.
Thinking, in light of your talk about cirrhosis, and whether it's liver failure or it's liver cancer, what are some of the best practices your clinic, and particularly thinking about the folks, your RNs and any other ancillary health workers you might have in your clinic, what are some of the ways that you've been able to effectively increase engagement in HCV surveillance?
Yes, sure. Well, I think that's a great question. I think the first thing that that's good practice is that this should be explained to the patient. So I usually tell my patients that regardless of whether I treat them or anyone else treats them, or if no one treats them for hepatitis C, if they have cirrhosis, they should undergo screening. So that is given at the outset. Then if they are treated and presumably they do respond, the standard practice is to create a standing order by electronic medical record so that those patients receive abdominal ultrasounds every 6 months, and in certain cases, I also check alpha-fetoprotein.
Well, thank you. So for those of you who are in clinical sites, this is something to check in with your providers if that's being done. And for those who are anticipating to do some community case management, perhaps we can start thinking about ways of reminding and reinforcing this education to our clients that, even though they've been treated and cured of, their Hep C, but if they were, if they were cirrhotic or just for their own liver health, the importance of checking in with that provider for ongoing surveillance. So we can think about that in our training education for those of us who create training education, but also for those of you who are thinking of taking up Hep C patient navigation. That was an area that our project unfortunately was not able to cover, which is why we invited Dr. Wu here to share some of his thoughts and suggestions. With that, thank you so much to Dr. Wu for spending some time this afternoon talking to us about this very important topic. I was looking at some numbers that are coming out of the VA and that initiative to eliminate hepatitis C among veterans, and it seems to be indicating towards this push for, what do we do post-SVR, and some of the insights you share with us, including surveillance, HCC surveillance, were some of the things that they're looking to introduce into their liver clinics. But also, really appreciate some of the resources you've shared, like the Liverpool website for those who are thinking about understanding, drug-to-drug interactions, and I'm sure, for anybody else who has any questions, they can reach out to you and be as much privileged by your expertise. So wanted to acknowledge and really thank you for that. And also wanted to thank the AECT at UConn, the church, Kim, and our friends who are up in the New England AECC for continuing to support education for us here. And we are greatly appreciative of your support to our project and particularly education. And to all of you, we really thank you for joining us. We do have one more training coming up on May 14th. I'll be sending out some login information to that training. And other than that, look forward to more emails from us in terms of how we're going to continue to provide education. Thank you, and have a great afternoon. Bye.
Thank you. Bye-bye.